Well, thanks for coming, everybody. My name is Joe Zamaria. I am a psychologist on the faculty at UCSF in the Department of Psychiatry and Behavioral Sciences. And I'm the chair of the selection committee for this event. And on behalf of the selection committee, it's my sincere pleasure to welcome you all to the 2023 Robert S. Wallerstein, MD, Visiting Lectureship in Psychoanalysis and Psychotherapy. So let's start today with some gratitude. First, thanks to the Wallerstein family and contributors to the lectureship for making this event possible. Thanks to the UCSF Department of Psychiatry and Behavioral Sciences for hosting this event since its inception. Thanks to the UCSF Psychiatry Residency Training Program, who worked really hard to help as many residents as possible be here today. On that note, I think it's increasingly important for these days for our learners to have exposure to events just like this one. And lastly, thanks to Gina Martinez, who works tirelessly with our committee to guide us and to make everything happen. So really a special thanks to Gina for all her hard work from the beginning and all her logistical skill. We have attendees here today in person in the auditorium of the Nancy Friend Pritzker Psychiatry Building here at UCSF, as well as many more people who are attending virtually on Zoom. And I just wanted to name that this is the first of these lectures with an in-person component since 2019. So that's notable, and it's great to see some faces in person. I wanted to say a few words about the namesake of this lectureship, Dr. Robert Wallerstein. As many here may know, Bob Wallerstein was a psychiatrist, psychoanalyst, and chair of the department here from 1975 to 1985. I didn't have the pleasure of knowing Bob, but his legacy speaks for itself. Those who I have spoken to about him talk about his identity as a researcher and a clinician, about his generosity as an educator, and his inclusiveness towards all mental health professionals. Dr. Wallerstein trained at the Menninger Foundation in Topeka, Kansas, rising to become the foundation's director of research and conducting a pioneering study called the Psychotherapy Research Project. He moved to the Bay Area in 1966 as chief of psychiatry at Mount Zion Hospital, and later joined the faculty of UCSF as a professor of psychiatry. Just a few minutes before this event started, I was chatting with Bob's daughter, Amy, who's sitting in the front row here, and she told me that Bob was responsible for integrating Mount Zion Hospital with UCSF. So it was a nice little tidbit I didn't know until just a moment ago. Dr. Wallerstein was a powerfully influential scholar and prolific writer. He wrote over 20 books, over 400 scholarly papers. And although I didn't know him, he represents something really important to me, which is an integration between the worlds of empirical research and clinical wisdom. Just like other important unions, head and heart, or mind and body, I believe it's crucial for the psychoanalytic community to continue to embrace the ways of knowing informed by clinical observation and practice, and by the vantage point provided by psychotherapy research. So I think this is a good segue to start talking about our presenter today, Mardi Horowitz, MD, who I think embodies that very principle of integrating research, empirical research, and clinical wisdom. Dr. Horowitz is a distinguished professor of psychiatry at UCSF. He has written 20 professional books and over 280 scientific articles in the fields of psychiatry, psychology, and psychoanalysis. He's a past president of the San Francisco Center for Psychoanalysis and past president of the Society for Psychotherapy Research. Throughout his career, Mardi has provided forensic consultations in the fields of PTSD, stress, trauma, personality, and psychotherapy. In addition, he has provided consultation to the media and governmental agencies on these topics. Mardi has a storied career in the fields of psychiatry and psychoanalysis, and it's really hard for me to try to distill that in just a minute or two of introduction, but I'll try. What I'll say first is he's a truly homegrown UCSF faculty member, having completed his medical training and psychiatry residency right here. Later, while faculty at UCSF, he established a clinic for treating stress response syndromes. And this led to empirical identification of criteria for the new diagnosis of PTSD and the official acceptance of this diagnosis into the psychiatric nomenclature in 1980. Delayed stress response syndromes in Vietnam veterans were predicted and found, and Mardi and his team found reliable modes of diagnosis and new methods for symptom tracking over time. Additionally, a new diagnostic category of complicated grief disorders was empirically derived. I could say much more. I have to distill it for just a few more minutes, but on a personal note, I just wanted to say Mardi is one of the first people I met when I started working here. I knew who he was, but he was kind to introduce himself to me, and we had many long conversations in his old office in Langley Porter about psychotherapy theory, about clinical practice, about residency education. And during the course of these conversations, he etched a deep imprint in my identity as a psychotherapy educator. Formulation is the foundational principle of my clinical and educational practice, and I owe a debt of gratitude to Mardi for helping me with this. So again, I could say more. I have to leave Mardi some time for him to give his talk. So it's my great pleasure to introduce our distinguished speaker for the 2023 Robert S. Wallerstein Visiting Lectureship in Psychoanalysis and Psychotherapy, Dr. Mardi Horowitz.
Good to see so many of you that I have worked with in the past, and this will be all stuff you know already, and experienced clinicians and trainees that are here. It's stuff you know already too, but the big principle in psychotherapy is awareness of awareness, and I commend that principle to you as we touch on familiar territory. I'm going to do 4 segments. First, I'm going to review some theory about how the mind functions after stress. I'm going to review research methodologies very quickly, and then I'm going to spend more time on stages of therapy and what happens, and then the importance of personalized formulation during each of these stages. First segment, theories of mind. The big principle is it's complicated. And we're still finding out a great deal from studies of stress, trauma, and loss. But we now don't think in terms of simple memory storages. We think of multiple memory storages with complex associational linkages in various biological circuitries. And these are both compartmentalized and connected. And part of the problem in working through the meaning to self of a stressful event is how to connect the different fragments that may be in different compartmentalized memory storages and different emotional arousal systems. And of course, they're biopsychosocial. They're not just in the brain, they're in the mind, and they're in the culture surrounding us and our cultural connections. So it's no surprise then that mental representations are in various places on a range from conscious to unconscious, from dissociated to integrated or consolidated, and the degree to which they may emerge to mental representations or social expressions as occur in psychotherapy may be controlled by unconsciously but motivated defensive control processes. That's why I will emphasize states of mind in what I talk about, because people are often unconsciously trying to prevent the intrusive experiences that may flood them with emotions such as fear or shame, guilt, anger. So it's no surprise also that personality patterns are very important in the process of psychotherapy change, and psychotherapy is the treatment of choice for the stress response syndromes. And in the deeper forms of psychotherapy, we're dealing with theories about unconscious but enduring and predictive schematizations of identity and relationship. What's going to happen if I get close or loving to this person? Will I be abandoned? Will I be nurtured? But if a person is able to go through various stages of adapting to a major loss or trauma or a cumulative set of traumas and even cultural deprivations, they may have advantages of gaining capacities that amount to personality growth. And part of our work is understanding how to promote that as well. So the big principle in therapy, as we all know in this audience, is the therapeutic alliance. And the therapeutic alliance is not just a concrete thing that exists, it's established and moving and can become even a corrective experience. And the safety of the therapeutic alliance can help the patient enhance their emotional control and endure and tolerate what otherwise is overwhelming as intrusive images. And they also don't have to dissociate and numb and not know that the traumatic event or loss has occurred. So as Dr. Zamaria referred to, I have been the beneficiary of tremendous research support, especially in earlier eras where there was less financial curtailment. So when Dr. Wallerstein came to UCSF as chair of psychiatry, there was an availability of faculty positions, and I asked for 5 of them to establish a research clinic where we would, in a way, step aside from the rigors of everyday practice, but be able to videotape and record and re-examine and re-interview patients. And I actually came to UCSF with an R01 that I had gotten in, from NIMH from when I was at Mount Zion. And NIMH eventually gave us a center for the study of neuroses. So I had a group of colleagues. And then the MacArthur Foundation funded a program of their own wishes of the Scientific Advisory Committee to really get into unconscious mental processes. So it was a program for the study of conscious and unconscious mental processes. I had many colleagues, including Kathy DeWitt and Janice Krupnik, whose names are earlier and later, but I won't go into everybody and what they did. They all did great things and advanced the field. We used different research designs. A group contrast is the conventional things in the widely used and excessively used, I think, term evidence-based therapies. And in group contrast designs, one has to curtail the design, cherry pick the patients, and have briefer therapies because one has to be able to finish the study within a finite number of months in order to analyze the data. Some of these studies can use correlation techniques, and that has been a primary methodology in psychotherapy research. What are the patient's symptom trajectories before and after, and how does that relate to the process of psychotherapy? And having videotape and being able to review it with independent and sometimes blind to condition judges allowed us to look at some of those correlations. And some of the findings were surprising, not only in our own UCSF studies, but in the field in general. I'll mention those. And that led to the mediator design studies, which are more complex and hence usually more expensive. And I wish to really get into the fine grained, which means intensive single case studies. When I started out, some of the journals were saying, we are no longer going to publish single case studies, because they were the observational based studies that clinicians were reporting without any empirical data or without any reliability statistics. But we found ways of getting around that by having the number not be in the number of subjects, but the number of judges who were looking at material, and I could empirically validate processes, including how best to formulate the changes that were gradually occurring in cases. So these different research methodologies had an impact on the field. Dr. Zamaria already mentioned that we were able to develop the criterion that were then used in 1980 for DSM-3, and more recently, the criterion that with other investigators around the country, especially at Columbia University, led to the diagnosis of prolonged grief disorder that just appeared in DSM-5 TR. And we also validated a number of scales, which I won't go into in detail, but they were able to track changes in the intensive single case studies. And so the evolution from the first diagnosis of gross stress reaction, which was in DSM 1 or 2, to DSM 3, PTSD, now has evolved to this group and its own separate frame of disorders. So the trauma and stressor-related disorders were lifted out of being in the anxiety disorders and had an improved opportunity for theory, bio, psycho, and social, by being in their own category. But these syndromes have very similar phenomenon, very different people. So personality variations cause a great deal of spread, but many people after trauma or loss have intrusion and avoidant experiences. In terms of the correlational designs, we were able to look at what in the process, reliably scored in various ways, was associated with more symptomatic improvement, and certainly not symptomatic deterioration. And the big finding in our studies and throughout the field of psychotherapy research is that the more there's an enriched, well-contributed, professionally framed therapeutic alliance, the better the symptom outcome before and after treatment. But we were surprised when we didn't find that the techniques of the therapist that we were measuring, how frequently or intensively they were employed, how that related to the patient's symptomatic improvement or not. So we, as people in psychodynamic and psychoanalytic research, including the Menninger Psychotherapy Research Project that Bob Wallerstein was in charge of before he came to Mount Zion, found that interpretive, exploratory, developmentally patterned interpretations by the therapist, the frequency of those interpretations thought of so highly in psychoanalysis and psychodynamic psychotherapy did not correlate with symptomatic improvement. And the frequency of supportive and coping advice to patients given by the therapist also did not correlate with symptomatic improvement. We were studying it in stress response syndromes. The Menninger project was studying it in more complex, in a sense, conditions. So we added these mediator variables, such as the organizational level of self and other schematization. I'll have more to say about that later, and the usual outcome variables. And we now found why we didn't find the expected results. Because if the person was functioning at a higher level, the more interpretive exploratory techniques, clarifications that had an interpretive aspect that the therapist used as technique, the better the patient's outcome in terms of symptom reduction. And the worse, the more the therapist kept giving advice and telling them what to do to structure their relationships. On the other hand, in patients at lower levels of personality functioning, the more those supportive coping advice-giving techniques the therapist gave, the better the outcome, and the more the deep interpretation, child, parent to current relationship, maladaptive pattern interpretation, the worse they did. So in other words, that accounted for the previous null results because the groups crossed over. And so that, in a way, inspired the single case studies. The case studies developed on an empirical basis how to formulate gradually deeper components of an individualized patient so that very personalized techniques might be advanced. And those intensive studies led to our understanding of stages of psychotherapy. So I'm now in the second component. This is just a quick laundry list in general, but the patient begins with a therapist and they assess each other. I want to repeat, each other. One thing with trainees that I like to do in teaching, which is to teach them a conversational style of sharing assessments rather than asking questions. Do you have insomnia? Yes, no. Do you have obsessive thinking? Yes, no. While an understanding, often shared assessment of symptoms and problems in living helps the patient establish the beginnings of a therapeutic alliance and to test their fears about therapists. They are further engaged in a supportive phase. The lower levels of personality functioning, the more this phase is indicated, and usually the longer. It may go on, and usually will in any case, to exploring meanings. What does this particular stressor, event, or loss mean to you now in terms of your present life and future expectations? Why are you interpreting it in a very doomed, the world is wrong way, rather than that this is a realistic trauma and loss? Why is it being totalistically framed? And this leads to a re-narration of the meaning of the trauma. It may even lead, in deeper cases, to re-narration of childhood traumas, because we're often dealing with people who have not had a single trauma, even though we tend to do studies focused on that, so we could do brief therapies focused on it. And then the deepest phase of the dynamic and psychoanalytic and integrative psychotherapies is re-schematizing. And the nice thing about the word schemas is it's a general psychological language that fits everything. So it's good for psychoanalytic discussions of transference and core conflictual patterns, and it's good for cognitive behavioral therapy approaches to modifying maladaptive beliefs in self and chronic emotional vulnerabilities to shame. And then, hopefully, successfully completed with reduction in problems, advances in personality capacities, the therapy draws to a close. For the trainees, it has often been valuable to just say who does what. in the present moment. So in assessment, the patient's reporting their symptoms, the therapist obtaining histories, and the therapeutic alliance is first established by agreeing on what is going to be done. In support, the patient expands on the story. The therapist provides some guidance, usually on how not to keep destroying relationships or how not to avoid social engagement, and defines the roles that they can take as they explore emotions. That allows exploration of meanings, and the meaning to the self of the traumatic event is what the patient usually is exploring, and the therapist is clarifying the linkage between emotions and ideas. In re-narration, there's themes that have been avoided so far that the therapist encourages the patient to explore and tolerate the negative emotional valences that occur as dysfunctional beliefs are being modified. And together, they have a way of engaging what someone has called safe emergencies, which is the patient brings in a topic and a set of feelings that have seemed overwhelming, even transference reactions that are like blaming the therapist for non-improvement, and they negotiate how to engage in and understand these difficult moments together, so that while they seem like an emergency and the therapy should be split apart, it's actually safe to engage and explore negative feelings. That leads to corrective relationship experiences sometimes, even in fairly brief therapies for a stress response syndrome, and the therapist helps the patient modify their internal working models. And then drawing to a close, the emphasis in the therapeutic relationship is on safe separation, which is why even in a time-limited dynamic therapy, one knows to engage in a discussion of the eventual separation, perhaps 3 weeks hence, before the last hour, so that the emotional transactions of what to expect and re-aroused feelings of abandonment can be integrated before the separation. The third segment I wanted to talk about is on personalized formulations, because as those stages of therapy progress from the more surface of what's troubling you and what brings you and what are your motivations and hopes, down to complex belief systems, requires an acceptance that the initial formulations, like an evaluation, may be important and necessary and lead to some treatment decisions, but they're usually in part wrong and almost always in part incomplete. So that the understanding of how to formulate what's going on has to be accepted as ambiguous and progressive, and also eventually to be shared. The patient's formulation of why they're feeling what they're feeling is not the same as the therapist's formulation of why the therapist is feeling that way or where it can go. And so they're each modifying each other's formulating in the present moment. Now, diagnoses are not an adequate compartmentalization or personalization. Many patients have multiple diagnoses. They may have the wrong diagnosis. They are descriptive at any rate. We don't have the causes, in spite of the RDoC attempts to find basic differences in neural system. Has not achieved success. It's worthwhile research. It's ongoing, but we still need our psychological and psychosocial and cultural formulations. And this is nowhere more clear than in all the discussions of complex PTSD. I just want to touch on that. And for the learners in the audience, I think you've already heard about this, but complex PTSD is the idea that a current traumatic event, like a loss in a catastrophe, is interpreted and understood in terms of past experiences, including adverse childhood events. And as that was emphasized by Alicia Lieberman, who's in our audience today, and gave the Wallerstein Lecture on this topic a while back. It's of interest, though, that in ICD-11, which has just recently come out, they've dropped the personality disorder classifications, and they do have complex PTSD. Whereas in DSM-5-TR, the personality disorders are still in a complex section for more research and studies, section 3, and the idea of borderline personality disorder and the empirical studies of various treatments for it have led to an understanding that PTSD, complex PTSD, borderline personality disorder descriptions tend to have fuzzy boundaries. And that when we do personalized formulations of a patient, that's where the level of personality function is important. So the configurational analysis method, I don't think that was a sign, has a beginning related to those stages of therapy. That is, an assessment, one is always getting the personal reasons, usually in terms of distress and suffering or fear of loss of control. What are the symptoms and what signs will be a focus, and how might they be tracked as one goes through a therapy? And a very important aspect of this is that the phenomena are not always present in every state of mind. So it's important to find what states of mind have the problematic phenomenon, which ones don't. And then in terms of topics, when one shifts from a working state into either a very avoidant defensive state or into an undermodulated state, what was the incipient topic that the patient was expressing? Often what emotions are being warded off or too intensively experienced, so the patient becomes flooded and disorganized. And these are the topics that will require safe exploration in the safety of the self and other views of the patient, the therapeutic alliance. So at this level of formulating, the therapist is tentatively considering and often floating out specific self-concepts, specific scenarios of relationship to other, and also appraising the patient's capacity for social cognition, since that makes a difference in the overall level of current personality functioning. And in an ideal view of therapy, the therapist has a plan for what to do next. I like to emphasize that this is a plan that's formed in the present moment in terms of what do I say next? Okay, so in terms of the first component of configurational analysis, phenomena, one would pay attention to complaint signs and symptoms, but one would not be too entrenched in the criterion for diagnoses, which are these symptoms, and focus intensely with the patient in conversations on what are the problems in current life. What are the obstacles to progress that both can consider? And what are the patient's preferences and goals? Phenomena tend to vary in the post-traumatic disorders, especially, from components that seem relatively less complex, like fear on a trigger stimulus. Person was an explosion and there was a chemical odor, and then bodies were shattered. And now whenever they come near that odor, they have a huge alarm reaction. But phenomena also include memory patterns. So people not only have intrusion as flashbacks, like of that chemical odor, but they may have recurrent bad dreams, and the dreams may be quite complicated. They have efforts to avoid thoughts and conversations that are embedded in preconscious codings. And they have efforts to avoid activities or places that might avoid recollections. And that leads to social problems, which are even more complex, such as excessive self-blame, shame, or guilt, excessive externalization of blame, rage, and revenge impulses, and feelings derived from defenses and dissociations, such as detachment, derealization, and depersonalization. Now, the blame issue is a question that often comes up in any trauma or loss, which is who's to blame. Even in a predicted passing of a loved one, the self of the patient is often reflectively going back over, could I have done more? Am I to blame for having wished this was over already instead of being an ongoing duress? And this is where the social aspect also is very important, because different cultures, even different religions, have different statements that are shared in a group of who to blame when something bad happens. And some of these you'll understand if I say are perceived as irrational by somebody else. And so this leads to a difficulty in this, which means that the personalized formulations may have to, when this important question of who's to blame comes up, consider the background experiences of not only the patient, but their cultural group. For each component, I'm going to mention just a few techniques, not just to remind you again of the stuff I'm sure you already know. But one thing is it often helps patients to use something like a jigsaw puzzle metaphor to tell them that they have memory fragments. And part of the job in the processing of the trauma or loss is to put these different fragments together so they become a cohesive story. And until then, the fragments may have their own dissociative life. And this is, in a way, a normalization kind of psychoeducation, even in the early stages of therapy. The second component of configurational analysis is that there are states. Now, in a personalized psychotherapy, one is always trying to use and share the patient's words for a given state of mind. So if a patient describes a mixture of irritability and depression as their blue meanies state, then you can use that word in therapy. And you don't have to use the categorical names used in diagnoses, which were overly fixated on anxiety and depression. Well-modulated states is a more general label, and I find that useful for us to discuss as professionals and teachers and trainees. So well-modulated, this is the three bears approach. Well-modulated is just right. Over-modulated is over-controlled and having too much avoidance of emotional expression. And under-modulated is having too much emotional expression. I like the term shimmering states when observing, let's say, a videotape of a therapy session, especially with a trainee, because the patient may have started in a well-modulated state, then they sort of shimmer into a little bit of a surge of emotion, like it feels like they're about to sob, uncontrollably, and then they throw in a quick second of avoidance maneuver, like, oh, enough of that, or I only felt that a little bit. And they shimmer back and forth, expressing emotion, taking it back, working on it, avoiding it, having it worked on again. So a shimmering state and a well-modulated state tend to be the working states in psychotherapy. Even at the surface level of looking at states of mind, we can have our traditional psychoanalytic wish, fear, defense configurations. So a person may wish to have a magical restoration of their secure, connected, safe life before the collapse of the building and the death of their family. They may fear that the wrongness they now experience in their entire world will go on forever and their life is meaningless and doomed. And they may defend against it by going off into some kind of dissociative belief of selflessness and independence and sunlight. They may wish for social in a relationship rupture. They may wish for socialization. They have fears of being rejected if they approach a new person, and they defend against an anxious search for a new social engagement by taking a stance of isolated indifference. I am an island unto myself. Techniques to stabilize states occur early in therapy, and they often involve a mixture of techniques. So I think we're facing at Neuro, we are going to integrate techniques. We should be using the calming techniques of breath control, improving sleep through CBT techniques, using mindfulness, progressive muscle relaxation, normalization discussions, instructions for how to regain stability. And we work with the patient to understand their state shifts and to predict when they're going to have them, so that they are prepared by discussions before they're going to have a difficult conversation, let's say, with their work supervisor about why are they taking so much leave after the trauma. In undermodulated states, in the therapy present moment, the therapist is usually using techniques of repeating what the patient says and slowly reorganizing topics, slowly in short segments and repeating it. I'm going to skip this case example in the interests of time, and because we're going to get back to case examples in our discussions, and I may come back to this. So in state stabilization, the therapist is piecing together with the patient the memory fragments and dissociated elements. Integration is the goal, and is teaching, even if it's a person with a vast psychoanalytic background, calming and relaxing practices that can be used in the present moment to regain a sense of self-efficacy. In overmodulated states, this is usually a big problem in the intermediate stages of therapy. The patient is explaining the value of frank and non-judgmental communication of emotional ideas. It's very important for the therapist to speak a lot, because that models calm, and it also deflects from the patient's ubiquitous fears that they are going to be criticized by the therapist for not expressing enough, or not being clear about it, or not moving fast enough, or having symptoms again. Also, in overmodulated states, the therapist often has a hunch what's being warded off, but doesn't quite know what it is. And so a very tentative interpretation may be offered. And I like the word that many teachers use, teaching therapy, floated out. I floated out the idea. We teach the patient how to clarify confusing medleys of emotion And I already talked about individualizing state labels. Then in exploring topics, it's very important to identify, sometimes at the beginning and end of hours, what are the topics that might be explored in this hour, and which ones might we want to bookmark for exploration in our next hours. And in doing so, we're saying it's hard to do this all at once. Especially in loss events, there was a lot of experimentation decades ago with let's do it all at once. Tear up the photograph of the deceased. Engage in primal scream. Go in your car and just scream how angry you are at the loss. And let's just do a psychodrama with a two-chair technique, and you tell the deceased what you wanted to tell them before the death. And with the idea that we'll be done with it in 20 to 40 minutes. Not going to happen. It's good to share with the patient that one make a little bit of increased awareness with such techniques, but it's going to be a gradual process. And elements of grief are not completed. Mourning is not completed. It goes on throughout life. It just is done in tolerable ways without the intrusions and avoidance. So it helps patients in general for the therapist to reframe the topics that have come up that have led to undermodulated states, and to repeat the warded off concepts that have been gradually clarified as patterns. Now, part of narration on topics is shifting the time frame to the future and saying when this kind of interaction with a potential close person occurs in the future, your present pattern is to block them from your phone and not engage in social media and not go see them for a date. What do you think your pattern will be in the future? And what would have to happen for you to re-engage in life and feel alive? And this is a pan-therapeutic engagement. It's not only the kind of CBT desensitization that occurs in the exposure therapies, it's the desensitization and preparation that occurs in psychodynamic and psychoanalytic treatments. And this means reappraising beliefs in conflicted topics. As one gets into reappraising beliefs, one is usually getting into issues of the habitual defensive style. And so this reminds me of a topic of memory that I'm going to say very quickly. In a dermatology lecture when I was a medical student, there was a confusing array of slides of all kinds of skin conditions with all kinds of salves and ointments and intravenous infusions and ultraviolet light. It was very, very confusing. I knew the whole class was confused. So I went up to the dermatology professor afterwards and said, Dr. Smythe, it was a lot to memorize. Are there no general principles? And he grabbed me by my name tag, which was up here then, and said, Horowitz, if it's dry, wet it. If it's wet, dry it. Now I preserved that memory in this slide. So I have two slides. What do you do when people inhibit ideas? And what do you do when people inhibit emotions? Well, the answer is when they inhibit ideas, you go for emotions. And when they inhibit emotions, and you go for ideas. So if they're inhibiting ideas and have just sort of a global emotionality and a flood of states, you encourage talking, you provide the verbal labels, and you provide the cause and effect tentative interpretations. And you encourage the patient to repeat your clarifications and agree or disagree. And you keep the topic open and you emphasize the step-by-step decision-making in deciding what to do on the basis of the ideas, instead of short-circuiting to the patient's usual erroneous conclusions. And if they habitually avoid emotion, we have bucket loads of technique. So we can often help the patient shift from their generalizations and intellectualizations to dealing with a particular memory, and especially getting into the richness of perceptual representations, including visual imagery, dreams, fantasies, images that are concocted in the therapy session itself, and holding discussions to one valence, even a positive valence, before shifting to a denial and a negative one. And that leads to the fourth component of configurational analysis, which is the hard one and the long one. But paradoxically, those patients who need it the most have the least capacity to get it. So with patients at lower level of personality functioning, they often need a lot of work on reframing their sense of identity, and they're changing their embedded relationship expectations, but it's harder for them to do it. So these therapies are often longer, and evidence-based treatments that cut it off before they can get to this are not in their long-range best interest. The big issues are identity and relationship patterns. The role relationship models, including the scenarios, will, I know in advance, be brought up in our discussions, especially with our next discussant. And this relates to the familiar psychoanalytic concept of attachment models and memories from adverse childhood experiences. In the reschematization stage, it often helps also to shift the time frame from the past to the present, to the therapeutic re-experience, perhaps in transference, to the predictive expectations of what's going to happen when the difficult relationships, opportunities for you, are presented in the future, and how can your capacities for thinking about this, being aware and prepared in advance, increase your capacities for social cognition, and developing identity coherence rather than segregated self-schemas. Now, transference will occur sometimes, and the typical non-personalized ones are a positive transference with a magical expectation that the therapist is going to, that the therapist is going to provide all what the patient needs. And then the negative transference, when they discover, as in the transference tests that Dr. Silberschatz describes with our trainees, when they occur, there's a finding by the patient that the therapist is not going to magically cure them, and then they may have anger at the therapist, and all the anger they felt at the world because of the trauma and the loss is now transferred in an immediate reaction to the therapist. That's fine. It's an opportunity for a corrective relationship experience as the therapist emphasizes the presence of the therapeutic alliance and what the patient has already experienced as safety in expressing even anger at the therapist. So I have discovered that it might be a good idea to summarize what I've said. The steps to recovery involve an early development of hopeful attitudes about symptoms and problems, and that can happen in the first session. To integrate memory experiences and fragmentation, that can be discussed in the first session, but it needs to be repeated and repeated and repeated because it is normal for these things to be very slow. Then the goal is to reduce maladaptive patterns and maladaptive state cycles and alter the wish, fear, defense configurations into more realistic configurations. And to help the patient choose better coping strategies, help the patient develop more coherent and stable self-images and self-esteem, and to re-engage in positive social relationships. So I think we can have a moment or two for questions and discussion, but I want to allow for a break for people to do it. So let's just keep, I will curtail it to some quick responses. And for the moment, I will just say all the answers are in these books. We'll have a brief questions, but it doesn't have to be questions. It can be short statements of a minute or two saying you're wrong about this and that kind of thing. But if you would speak into the microphone that will be delivered to you, if you raise your hand, then the people who are in our Zoom audience can hear the question and answer. So, do we have any takers, comments, questions?
Yeah, I'm wondering what you see the role of the patient's agency, like their intentions for what they want to get out of psychotherapy, or how the therapist might account for or use what the patient's trying to do in therapy.
Yes. Patients often are not coming for the symptoms that they use as the ticket of admission. So as you get into developing the safety of a therapeutic alliance, the issue of their intentions and desires and preferences is a question to just raise for very serious contemplation. And it includes the intentions and expectations and hopes of their family and friends. So they are often in social contexts, and even collaterals may be calling in with this. And so I think the focus is always in the present moment. What is the patient hoping for? And then it's a conversation like what's maybe possible. So that's often not what they're hoping for exactly, but it's an important psychoeducation. And it also is a tentative flavor, which is, let's see what will be possible. Let's make this a safe situation for dealing with some difficult topics, and we'll see how that is helpful or maybe not helpful. And we'll have a lot of feedback back and forth as we see how this progresses. So the patient often wants a blanket reassurance. This XYZ therapy is 99% likely to be totally improving you. And the therapist has to say, not exactly. And gradually, confront them with what's possible. Any other? I'll just highlight one, I see, highlight something I said during my talk, which is some patients expect grief to be like Kubler-Ross says. You go through the stages and then it's over with. They're often surprised to find out that there may be phases of return of grieving, but certainly what's lost is not lost in memory. And it remains lost in reality. It may be replaced or substituted, and the individual may progress, but it's not like you go through a certain procedure and you're desensitized. Was there a microphone somewhere? Yeah.
So it would seem maybe nowadays, perhaps worse than in the past, that because of the reification of psychiatric diagnosis in nosology, that patients will come to treatment thinking of their being depressed and symptoms of depression being the problem, and perhaps are not as curious about whatever else they might be bringing or might be interested in from the therapist or the therapy, and might have some difficulty thinking beyond that they're bringing, which maybe creates more problems in short-term treatments. Do you have any thoughts about how in the supportive phase you might try to elaborate this or move past this, I suppose, particularly with people who are maybe especially rigid about such things?
No, I'm going to try and repeat the question and raise your hand if I don't do it well, because I think I'm repeating it as, what about patients who come with depression and in a sense believe in their depression? They believe it's going to be ongoing and that depression has to be treated. Okay, so that's pretty ubiquitous. And that's why I often like with trainees to differentiate between the words formulation and formulating. Formulation is a thing, and formulating is a verb or action. Formulation often refers to what we do when we're doing our evaluations as a diagnostic formulation, and that's biopsychosocial, and it includes diagnosis. And so a person may have all the signs and symptoms of a major depressive disorder. They even may be a person who's had history of manic episodes and warrant a diagnosis of bipolar 2, and they're still coming in because a recent stressor event impaired their social functioning further, even though they may be on stabilized diagnostic platforms. So you deal with the whole person and their whole culture, including their psychopharmacology and expectations and what their family history is of, let's say, depression or bipolar or other conditions. And that's just an aspect of reality. And that diagnostic formulation, biopsychosocial, and the transaction between them then goes into a therapy, which is, let's say, a psychotherapy related to the current problems in living and personality features possibly, and considering depression as what are your states of mind. And so we want to get into the particulars of your state of mind, including, are you having states of apathy where you can't get out of bed? Are you having, how do you describe what you're calling pervasive sadness and the wrongness of the world? When do you enter that state? What gets you out of it? What are the alternative states? How long has it been going on? What experiences seem to have brought up this exacerbation of it? And what are your ideas about your brain and its metabolism and how that contributes in your nutrition and exercise? And that is you're formulating the whole thing, and not just the fact that the person may have had previous episodes of depression and may currently be on an antidepressant or some other kind of medication. Short answer to a very complicated question. So,
thanks, Marty. There will be ample time at the end for further questions, so please hang on to them if you have them. Hopefully more will bubble up as we hear from our other discussants. I would like to introduce our next discussant, Catherine DeWitt, PhD. Dr. DeWitt is currently an adjunct senior lecturer in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, where starting in 1984, she also served as a clinical supervisor in the psychiatric residency training program. Kathy did her graduate training at UC Berkeley, and over the years, she has held numerous positions in teaching and research in the Bay Area. Relevant to today's presentation, in 1980 to 1983, she was an assistant professor in residence in the Center for the Study of Neurosis, participating in all aspects of the center's research on trauma and bereavement. In 1984, she joined Dr. Wallerstein's project on character change in psychoanalytic psychotherapy and psychoanalysis. As an outgrowth of that project, in 2007, she, along with Dr. Constance Milbreth, partnered with Dr. Wallerstein in conducting developmental studies of the Wallerstein scales of psychological capacities until his death in 2014. So let's all welcome Dr. DeWitt.
Yeah, okay. Thank you. Good afternoon, everybody. And as Dr. Zamaria just mentioned, I had the good fortune to be part of research teams that worked with both Dr. Wallerstein and Dr. Horowitz, which was just absolutely made my whole professional career more interesting and rewarding. Dr. Wallerstein was simply the most positive and productive human that I ever known. He had a strong commitment to the psychoanalytic perspective, but also an embracing open-mindedness about alternate conceptual systems, which was particularly remarkable at the time that I knew him, when people were very loyal to their point of view and there was a lot of infighting going on. Bob was open-minded. And no source of information relevant to research and practice of effective psychological treatments was neglected by him. Working with him for 32 years was a wonderful experience. He was a true phenomenon, and our world is better for having had him in it. Like Dr. Wallerstein, Dr. Horowitz, as he mentioned in the presentation today, embraces all ideas and techniques that have been proven to make a positive contribution to effective psychological treatments. I've also found him to be unusually creative in developing conceptual systems that can be used by practicing clinicians in their day-to-day work with patients, especially those suffering from PTSD or bereavement. So I am going to give you a case example, including the process of one session with a patient, to give you a feel for the flow of how you would do some of the things that he described. And I chose the patient because it gives a sample of both the phenomenology of trauma and the kinds of typical psychoanalytic techniques that have been found to be effective in the process outcome studies that Mardi mentioned in treatments for them. I treated this patient as part of a research study of the behavioral treatments for depression. And based on intake screening, she was found to be appropriate for a 20-session course of psychodynamic psychotherapy, so 5 months of weekly treatment. Study subjects gave consent for their audio tape sessions to be used for research and presentation. So I'll begin with the, your standard patient description. At the beginning of treatment, the patient was a 63-year-old divorced woman with 2 grown children, currently unemployed. Formerly, she was a financial planner for a very large public institution. She was living with her younger sister, a nurse, and she was referred to the study by her primary care physician. At intake, She met criteria for major depressive disorder, endogenous type. She was not getting out of bed. She had slowed down. She wasn't really eating. She had all those kinds of symptoms, serious symptoms. She also had simple phobia for crowded places and spontaneous nighttime panic attacks. She reported no history of mania, hypomania, alcohol, substance abuse. The only previous occurrence of depression had been 30 years prior at the time of her divorce. So the precipitating event was complex and quite traumatic for her. On her way home from a visit to her son and his family, she slipped on some refuge. They were like orange peels, stuff like that, that had fallen out of an overfilled waste container in a crowded airport. So she slipped and fell, and that resulted in a fractured hip and extended hospital stay and convalescence. As a result, she was unable to return to work and in time to complete the requisite number of pre-retirement years of employment, and she lost her pension. So you have sort of a horrible experience. It has physical sequela. It has economic sequela. So most people wouldn't get over that right away. Okay. In terms of her character and general functioning, the patient was an intelligent, organized, restrained, and private person who valued self-reliance. She had numerous friends and was on good terms with members of her nuclear family and extended family. The family history: the patient was raised during the Depression by parents who were college educated but poor. She was the oldest of 4 children, 2 girls and 2 boys. Her parents valued education and sacrificed to send their children to private school. And finally, she had rheumatic fever as a child, which left her in frail health until into her teens. Okay, so at this point, what I'm going to do is I've divided this session 5, the 5th session with her, into episodes. It does this very easily, and each episode I've got a slide on it, and I'll put it up on the screen and I'll read it. So I invite you to read along with me, and then you'll see how she said, I said, she said, I said, and how that progresses through the session. Okay. Sessions 1 to 4 were spent going in a great detail over her experience of that trauma. So we had full 4 sessions to kind of settle that down, have her talk about it a lot, have her not be as overwhelmed by thinking about it, having her get to know me, and having me get to know what kind of person this was. So using Mardi's words, labels, this session 5 is devoted to narration as she describes and thinks over a series of traumas that she brings up spontaneously, and re-schematization as she thinks over her identity, just who am I, and who was I, and who am I now, and also her relations to others. As the session progresses, her context shifts from past events as an adult to childhood events, and finally to current events. So we get this series of episodes. Also, because the patient has capacities for collaboration, she's social, she can work with people. A lot of patients that you see will not be able to do that very well. This patient could. She also could self-reflect and was good at self-expression. So that meant that my interventions could be entirely expressive. It also, what the research that I did with Dr. Wallerstein had to do with actually having ways of describing capacities that people can develop in therapy or bring to therapy. So this particular patient brought a lot of positive capacities to therapy, which meant that I could work with her entirely expressively. If she didn't have those capacities, I might have had to, for example, have her take other kinds of treatments in addition to my work with her, where she would do something like learn mindfulness, figure out how to settle herself down when she was trying to figure these things out. She could do that when I was talking with her. Okay. So what we're going to do is read this session, and then I will make some comments on the process. Okay, so we start with the first one. Traffic was heavy on the way here. Once I walked away from the mic. Once I nearly hit a car. I didn't see it in my peripheral vision. It was such a shock to me that I still avoid that area. It would have been so devastating. I avoid it because I can't rationalize it and make it normal. I can't go back there. I get a rapid heartbeat still if I have to adjust to cars coming at me from the same position, like an on-ramp. I'm trying to think of what the problem is. An on-ramp feels like bullets coming at me from every direction. It's almost ridiculous how I avoid it. I say, was it that you were surprised? Yes. You want to be able to know what's going on at all times? Could be. Like you're worried that you might fall again. I'm especially worried in a crowd. I feel like I did because I can't bear the element of surprise, of anything that I can't control, can't handle with finesse, that's unexpected. So the patient begins by relating an earlier trauma, describes characteristic responses of panic and avoidance of reminders, and due to and resulting in a failure to process the event. If you avoid it, you're not going to be able to really think it through. And so one of the things that we as therapists do is we provide a holding environment, Winnicott, and in which she's able to process things that she would normally avoid. The therapist makes a summary statement, and I tie the past trauma to the current one, because we're trying to work through this past trauma she just thought up simultaneously with working up the one that she brought to treatment. And she actually ends up working through quite a number of related traumas, all of which have something to do with her character. Okay, and I comment on the patient's need for control. Now, because I had worked with her for 4 sessions, I already knew that she had a characterological need for control, and that I was hoping to sort of move this a little bit and get her to be less obsessionally rigid. Okay, so that in the next one, I did it. Okay, so you say for finesse, is it that you don't trust your ability to react? Or are you concerned about being graceful? She says, I'm concerned about being less than graceful. Surprise is intimidating. My second daughter nearly died of hemorrhage after an operation. I knew something was wrong. It had been 7 or 8 days. She was very pale. I brought her to my bed. At 11 p.m., she said, Mommy, I'm sick, and threw up a lot of blood. I quietly and calmly took care of it without alarm, called the doctor, got her to the hospital. Afterwards, he said that if I'd shown alarm, she might have died of shock. I doubt that he said that. But they had difficulty giving her a transfusion because her blood vessels had nearly collapsed. Somehow I'd known that something was seriously wrong so I could handle it. If I don't know, I feel that I can't. I say, you feel that you need a warning. She says, then I know that I won't run amok and do dumb things. Having things be totally out of control is upsetting. What would happen? It would be terrifying. Like when you fell? Yes. Now, when I'm in a crowd, I imagine it could happen again. It's never simple, like turning my ankle or something. It's always drastic, like an epileptic fit. So you see her style of catastrophizing, of making it dramatic, making it more difficult. So here I continue to flush out the details of her need for control. So my aim in this therapy, as I mentioned, is to work on her character so she goes away better able to handle other kinds of traumatic events. The patient responds by relating another trauma, including an example of her desired self-image, which is being graceful, along with her dreaded self-image, which is being out of control, having an epileptic fit, not being graceful. Once again, I tied it to the incident and to the current presenting problem. Okay, next one. Okay, she goes on to say, like once I was with my daughter and granddaughter at the hospital. Her child was ill. I said, I think I'm going to faint. I just crumpled on the spot. Because it was a children's ward, they brought a child-sized gurney. And I was drooping. Now, the patient was 5'10". Okay, and I'm a pipsqueak. So she would comment on that, on the difference in our heights. And okay, so I was drooping all over all the sides. When I awoke, the first thing I said to my daughter was, did I keep my knees together? She said, yes, mother, you were the perfect lady. So the daughter knew her mother well. Okay, she knew that it would be devastating to me to be out of control like that. I'm very fearful of having no control over what I do. I say, it feels unladylike, like having your skirt over your head. I can't think of how bad it would look. I get this rapid heartbeat. I feel as if I'll die. You need to be graceful. With my knees together, there is this strong need in me. I say that's true for any accident and also in general. You said you want to age gracefully. To be unattractive is painful, embarrassing. You almost get a creepy feeling. So what I'm trying to do is what Marty was talking about, which you move in the feeling state and integrate it with the ideas that go with it. I'm almost rather die than face it. The feeling, I say. I can't cope with that feeling. I have good patterns in my background for aging. My mother developed a softness in her old age. It was like she became happier. Her hair was silver, like a halo. My aunts and uncles aged gracefully, so I have good patterns to follow. But it's also true if she doesn't age gracefully, she's not going according to pattern. And she's very afraid of that. So in that session, she goes on to relate yet a third incident, another trauma, highlighting her need for control. And I provide a visual image of the dreaded self-image and tie it to a feeling state. She's clearly reflecting on developing the theme that we are discussing. She's collaborating with me. This patient and I are in sync during this session. Okay, next. So I say, I wonder where this worry came from then. She says, someplace. I say, are you unlike your mother in some way? She says, I guess I favor my father. I'm taller, tallest of the girls. Are you taller than your mother? Yes, 8 inches. She was 8 inches taller than I was. Okay, so she was clearly having a kind of transference to me, which we in later sessions talked about. Well, yes, I was that significant in some way? Well, yes, I was always awkward. I was this tall in grade school. The tallest in my class till junior high. It was a difficult thing. My clothes didn't fit. So the issue of being ladylike probably felt kind of acute during that period. I'm trying to hunt around and see what this has meant to you. It could be that I was awkward. So here I shift the focus to historical. So I did a shift to history. Let's figure it out, see if there's anything historical. And she supplies relevant material, which I summarize. So she laughs, and she does it in embarrassed. It has an embarrassed tone. That what I have said. She says, "I remember slight." So she has a recovered memory, which is interesting in the session. And she says, "I remember sliding down a slide, and my dress blew up. And my parents were frugal people. I had on these black bloomers and black stockings. It set out in my memory. The other children teased me about my black bloomers." So that is a social trauma. And it's very important part of why her character formed the way it did, along with what her parents were like. You've been trying to protect those black bloomers symbolically over the years, I say. And she says, "I haven't thought of that for such a long time." I said, "You wear pants more often?" Because I had noticed during a time when not all women wore pants that she did. And she says, "Yes, I had trousers on when I fell. And that was one thing that was a comfort to me." I say, to be awkward is discomforting. It's as though, she says, it's as though I need to be in control at all times. So this is a summary interpretation. If you're not in control, you're in danger of being embarrassed. So, which is, of course, the common motive for obsessional character, has to do with shame and trying to avoid shame. So the patient responds with a relevant early memory. I make a summary statement and tie it to the current behavior and to a summary of her characterological concern. Also, I'm concerned about needing assistance. Now, she expands here of her own volition into a related psychological issues. I don't want to ask for help. You even push away help. Don't help me. I guess that 12 layers down, I need to be helped, but I can't get the layers off. I'd rather help myself. Now, of course, she doesn't ask for help because it feels vulnerable to her. And what are those helping hands doing? I don't know. As much as I love my children, I don't want them to help me. It's almost absurd. I love to help my mother and dad. I'm denying my children that. It was almost good fortune that I broke my bone because I had to accept my son's help. It was good for him and me, the best thing that could have happened for our relationship. I say it would be pretty personally expensive if you had to break a bone each time. Okay, now, so that was an attempt to make an interpretation using humor, and it worked because it all felt really heavy at that point, and I was trying to kind of soften it. So the patient expands the theme of control to include a reluctance to be helped, a shift from internal experience of shame to their effect on relationship roles. So she's now talking about both. The therapist restates her comments, adding an interpersonal image, and makes a humorous aside intended to give perspective. Okay, the final episode. Okay, she laughs. I know that. That was a plus. Yet I know that if the time came again, I could be stubborn about it. Like I remember a time when I worried unnecessarily for months about whether I had a blood clot. I say, you said stubborn. She says, it's like a flaw in my makeup. My sister calls me a stubborn Swede. If I make up my mind, I stick to it, even if I shouldn't. I can't say, you're right, I was wrong. I say, you said that your stubbornness as determination has gotten you over some difficult times. She says, yes, but I would like to make graceful retreat. So she responds in her characterological self-labeling. You can see she has a very severe conscience and superego, and she states desired relationship goal. She would like to dampen that a little bit. And the therapist makes an attempt to soften. I was just sort of watching her beat herself up, and it drove me to try to calm her down a little bit. And that's why I said what I did. Okay. At this point, I'd like to switch to a summary overview of the treatment in general. As part of the work of the center, we explored and applied various systems of formulating a patient's individualized patterns of relating to themselves and others. So as a patient's character, of course, as you know, is an important contributing context for symptom resolution. And attention to that context can result in changes beyond symptoms, which is what we really want to do. We want to settle down the symptoms, but we want the patient to go away in a better place to be able to endure disappointments and other kinds of problems in life. So in my comments in episode 2, in relation to her discussion of her need to be ladylike, I used Mardi's role relationship model system of desired, dreaded, and compromised self-images. Okay, so I talked about the desired, she wants to be ladylike, dreaded, she's afraid she's going to be, puddling over on the side and look awful or have an epileptic fit. And as you know, toward the end of the session, she's considering shifting toward a more flexible, compromised self-image when she's talking about maybe I should be able to talk more about needing help, admit when I need something, be a little weak, not be strong all the time. Other systems like this were developed by the Control Mastery group headed by Sampson and Weiss, and the Core Conflictual Relationship group headed by Lester Laborsky at Penn. The CCRT system is a really good fit for this patient because of all these episodes. And so I use that. In the next slide, I'll show you how it's used, where you put the material from the patient's comments into a table that helps you summarize it. Okay. So, as you can see, the columns break each episode into the object. That is the person who's the focus of the narration, the aim in relation to the object, the response of the self, and in interpersonal episodes, the response of the other. So looking at the first episode, it's focused on the patient's near miss in traffic. Remember, she had almost got hit by a car. The object is the self. The aim is to be in control. The response of the self included shocked, devastated, avoids area, tries to rationalize it, rapid heartbeat in similar situations, cars feel like bullets, and feels she's being ridiculous. After the therapist ties the incident to the presenting problem, she adds that she's now worried in crowds, which would make sense. She fell in a crowded place in an airport. Okay. The CCRT components in the next parts of the table are similarly summarized. So I'm going to give you all of that table. So if you want to just look it over a little bit, you can see how that works. Okay, once the table is constructed, it's used to create an individualized formulation. And the next slide, I'll show you how I put together a formulation based on the table. Okay, here's the formulation. This somewhat elderly woman would like to avoid embarrassment at all costs, to the extent that she feels as if she would rather die than feel embarrassed. She responds by trying to anticipate what's coming, know what's happening, handle all emergencies, be correct, graceful, self-reliant, in control at all times. She realizes that as a result, she spends unnecessary time and energy worrying to a degree that feels ridiculous to her. If she fails to avoid a situation that results in embarrassment, she feels terrified, devastated, experiences rapid heartbeat. She copes by trying to analyze the situation to avoid similar experiences by changing her behavior. She also tries to put the memory out of her mind or rationalize it, make it normal. However, these methods fail at times, and she finds herself worrying and imagining drastic conditions. She would like to soften her intense need to avoid embarrassment as she realizes that it interferes with her willingness to accept help from others, admit that she may be wrong, and make a graceful retreat. She's coming to understand that her relationships would improve if she were able to make this change. So I will end with an outcome assessment of the patient. So this is after the 5th session. I had 15 to go. So we were able to do a lot of work going forward. At 3 months post-termination of her 20-session treatment, she no longer qualified for any DSM diagnosis. She was not depressed, not having panic attacks, showed no evidence of phobia. She was driving in traffic, going to shopping centers, had resumed daily walks with friends. She did make note of some reduced concentration and memory capacity, along with reduced energy, but attribute these changes to normal aging. In terms of social and work functioning, the patient was employed half-time in a position that was interesting to her, but not as challenging as her previous job. She was spending more time with friends, reported she had shifted her focus away from the details of management toward appreciation and enjoyment of others. She also reported that she'd become increasingly able to confide in and depend on others and become more self-indulgent. Then finally, some months later, when I was approached by a lawyer, I learned that she was in the process of suing the airport authority for negligence in not maintaining a safe level of terminal cleanliness. This concludes my presentation. Okay.
Thanks so much, Kathy. So next, we're actually going to assemble as a panel here, Dr. Horowitz, Dr. DeWitt, myself, and one other discussant who I would love to introduce to y'all. Our fourth panel member today, our other discussant is Jonathan Shedler, PhD. Dr. Shedler is a psychologist known internationally as an author, consultant, master clinician, and teacher. Many here may know that his article, The Efficacy of Psychodynamic Psychotherapy, which was published in American Psychologist in 2010, won worldwide acclaim for establishing psychodynamic therapy as an evidence-based treatment. It's been cited thousands of times. It's been downloaded, I think, 250,000 times. Dr. Shedler is also author of over 100 scientific and scholarly articles. 12 of them were in the American Journal of Psychiatry. He's the creator of the Shedler-Weston assessment procedure, the SWAP for personality diagnosis and clinical case formulation, and co-author of the second edition of the PDM, the Psychodynamic Diagnostic Manual. Jonathan has more than 25 years experience teaching and supervising psychologists, psychiatrists, psychoanalysts, and we're fortunate that he's a volunteer clinical professor here in our Department of Psychiatry and Behavioral Sciences, where he is responsible for psychotherapy education. He's a supervisor for our 3rd and 4th year residents. So let's welcome Jonathan as we all assemble as a panel here in front of you all. Thank you.
I thought I would kick off a discussion. We're gonna have a little discussion among ourselves to start things off, and then involve the whole audience, including the audience who.
I think there's. Can you speak up a little, or mic a little closer to your mouth?
Hello, hello. Can you hear me? So the plan is we're going to have a little bit of discussion among ourselves, and then we'll branch out and include the audience, including the audience who's participating by video. And so if you're participating by video and you want to participate, I'm told that the thing to do is to say in the chat window that you'd like to add something or to pose a question, and then we can turn on your audio and we'll all be able to hear it and have a discussion. So that's the plan. I want to kick things off by sharing a few thoughts that I had as I was listening to Dr. Horowitz and Dr. DeWitt, and maybe situate these lectures in the larger context of what I see as some unfortunate trends going on in the mental health professions around trauma. So I see two different trends that both of our speakers today, fortunately, managed to stay clear of. And one of the trends is that you can treat the trauma as a thing in its own right, and you can treat trauma and only trauma without really consideration for the person who has the trauma and that person's life trajectory and that person's psychology. So the most commonly known form this takes is that we have evidence-based treatments, therapies, which is a code word, of course, for brief manualized therapies, treatments that are conducted literally by following an instruction manual. They're very short. They're typically 6 to 8 sessions, maybe 10 at the most. And the idea is that you can treat trauma as a kind of a compartmentalized, modular, encapsulated thing. The problem is the diagnosis rather than the psychology of the person and the life trajectory of the person who has the diagnosis. So that's one approach to trauma that is getting a lot of attention these days in the mental health professions, right? Trauma as an encapsulated thing. The patient comes for trauma, the patient gets treated for trauma, goes on their way. The other trend going on in the mental health profession is usually goes by the name of trauma-informed care. Everything is trauma-informed. You can get trauma-informed therapy. You can get trauma-informed education into classroom. You can get trauma-informed yoga. You can get trauma-informed meals. And in a way, this is the opposite problem. See, in both cases, what these two very different ways of thinking about trauma have in common is that the person disappears. Right? In one case, the person has an encapsulated problem with a diagnosis a diagnosis of trauma. In the other case, we're going to look at the person's entire life, but everything about them is filtered through the lens of trauma. And, so the trend, and if you're on social media, especially Twitter, you see it all the time. You can pick just about anything in the world that you can think of that is problematic for someone somewhere, label it a trauma response, and now it gets talked about in terms of trauma. So what I want to say is, listening to Dr. Horowitz and Dr. DeWitt, we're really steering a middle course here and not succumbing to either of those, right? Not succumbing to either of those trends. And the middle course is a recognition, right? Trauma can have catastrophic effects on a person's life, but it doesn't happen in a vacuum. Right? There's a recognition that the person who experiences a trauma comes to the trauma with a certain life history, life trajectory, trajectory of life experiences, a certain psychological makeup or psychological organization, right? Patterns of experiencing self and others and the world, right? And that pre-existing psychology really shapes what their experience of trauma is, and in fact shapes given the same external traumatic event, even shapes to what extent it's even experienced as a trauma. So the person comes in with a history prior to the trauma then does something, right? If it's really severe trauma, that trauma then shifts the person's organization again, right? And they have an entire life trajectory following the trauma. So the thing that stood out for me in both of these presentations is, we're not going to let trauma disappear in the context of some pre-existing psychoanalytic theory that leaves out what happens to the person. But we're also not going to forget about the person's psychological history, right? So what I got from the two presentations is, can we think about trauma in an intelligent and coherent way while simultaneously thinking about its place in the person's larger psychology? And I think that's the contribution, relatively unique contribution, of a psychoanalytic or psychodynamic perspective and how we work for trauma. So those are my introductory remarks. I could say way more, but I thought that might be a nice way to kind of kick off some discussion here. And there's a life lesson here. Always look behind you because you never know what might be going on. So,
thoughts from Dr. Horowitz or Dr. DeWitt about Jonathan's reflections?
I like the middle ground. It is an excellent metaphor for our highly polarized times. And just to rephrase what's on the other two sides of the middle, I like to use the metaphor with trainees that with a patient in therapy, you're walking down like a sidewalk in the Everglades. And you can fall off the sidewalk on one side with alligators and the other side with crocodiles, probably a bad natural history. But on one side, you can fall off into an excessively narrow thing. Now we have to work through with a regimented exposure, the particular experience you had in the cockpit of your airplane. And on the other side, it's everything is your cultural background is traumatized. Your education has been traumatized. Your current economics are traumatized, and you're living in a trauma world. And we have to maybe change the world so it doesn't traumatize you, and find an activation for that within you. And the middle ground is, here we are. Where do we focus next on the whole understanding of what's bothering you?
Well, you just reminded me of something I wanted to say. You spoke in your talk about the centrality of blame when somebody has been traumatized. When I think about what's discussed out there, especially on social media as trauma-informed care, seems to have two major components. One is it's all about soothing and stabilizing, right? Not changing something about the person's enduring psychological functioning, right? Soothing and stabilizing, basically one stage of the stages of treatment that you discussed. Or it's about finding someone or something to assign blame. Right? So in a way, right, I think you see and we see blame as something to understand and work through, whereas there's some other approaches to therapy that seem to be organized around the project of assigning blame. Very different.
Jonathan, I actually had a question for you. Oh, Kathy, were you about to speak up? Okay. If this is out of the scope of this talk, I fully understand. But do you have a sense of the cultural, the sociocultural forces that have created these phenomena that we see, that you just described, these polarized positions about trauma that clinicians can find themselves in?
Yeah, I think it got swept up in the culture wars, which are kind of hard to get away from anywhere. And part of what the culture wars seem to be about, as I understand it, is a worldview that wants to divide the world into two categories of people or two categories of experiences. And there's oppressors, there's sort of privileged oppressors, and victims. And I think if you superimpose that worldview on psychotherapy, I'm not sure it's psychologically helpful for people in working through their trauma. And so the therapy then becomes about, well, are you the oppressor, and do you need to take responsibility and accountability for your role in creating oppression in the world? Or are you the victim, in which case we need to understand, how you're being victimized and oppressed. And to me, it's not a very psychological way of thinking about somebody's functioning.
I think it's on.
Hello, is it on? Okay. Yes, thank you. Okay. I think there's some other elements that are there. I agree with what's being been said. I don't want to just echo it, just say I agree with it. The other thing that happens is that it's true that I think that we're trying to deliver some kind of a helpful treatment to as many people as we can. That means that people move into trying to manualize in a way because they can make it shorter, they can make sure that they get all the ingredients there, they can deliver it to more people. And so whereas individualized treatments require better training of the therapist, they have to really think about what it feels like to be a person. They have to understand character. They have to understand how to relate to character. They have to understand all kinds of very complex things that happen in a therapy that's actually individualized. Okay. And so, for example, that you can, with someone who is not naturally like the woman that I presented, would not naturally put things together, could not usually think about or take what you would usually call an interpretation of linking their childhood with their adult behavior. But if you think about what's going on in the relationship, okay, if I say to that person, I was thinking about what you told me about what your mom was like. And it seems like the way that you're reacting to this has a little bit to do with that. I don't know if you agree or if this makes sense to you. Okay, that's to get them engaged with them. Okay, then I can make the link and say, gee, this way you're doing is sort of like that she used to do. What do you think? What's actually happening is not intellectual. It's actually interpersonal. They have me interested enough in them to think about what their childhood was like and what it might mean for what's going on now. Plus, if they're doing things that they think and other people have been criticizing them for as stupid, okay, they now have me saying, because you're doing this now, because you learned it when you were little and you had to do it that way because of what your family was like. So knowing that person can respond to all kinds of implicit things that are going on in the relationship. Understanding the delicacy of all those ingredients is a very sophisticated thing for the therapist in training, and it takes time. Okay. It can't be manualized. It can't be, but it's extremely powerful. Okay. So I agree with what's being said about absolutely, you need to know their character. It needs to be individualized, et cetera. But trying to deliver that to a lot of people in terms of the goal of not being elitist, which is part of the culture wars that's going on, it's very difficult to figure out how you're going to make that happen in practical terms.
Yeah, I think we can open it up to the audience, both those who are attending virtually and as well as those who are here in person. Was there a question in the back?
Come on down. Or talk loud.
Or he'll come up.
We have a runner.
We got a runner.
Thank you so much for this event and for this opportunity to think in a nuanced way about the point counterpoint and about this particular treatment. I'm interested in two components of what she said. One is the fact that the first thing
You need to bring your mic closer to me.
The first thing she thought of was, were my knees together? Yeah. And another association that she had was these scars were like bullets. I was thinking, if this woman was Guatemalan or El Salvadoran, or if she had, as a Swedish woman, she had worked in a place of, with turmoil, that would be such a rich association. And the question of the closed knees, I might be working with traumatized children, sexually abused children, and so on. So for me, the first thing is, when else didn't she have her knees together? And what I'm wondering is, in this particular approach that you are describing to treatment, how do you make decisions about when to pursue a particular association that could be so full of meaning in terms of what it evokes?
I think the way that you do that is I too thought, okay, what are we're talking sexual here when she said the knees together part. And later in the treatment, we talked about her sexual history and what her marriage was like and why she got divorced. And it did include some rough sex that she did not like. Okay. So, but in that moment, that was not where we're going to go. Okay. In that moment, if I'd gone there, I would have really shocked her. Okay. Because that was not where she was at. She was at talking about other things that were much more global and not quite as personal as that. But you're absolutely right. And now she didn't have, I don't think she ever had an experience of war or anything having to do with bullets, actually, as an association, but definitely there was a sexual association. And what was also interesting in terms of, control, mastery, and enactments is that in the next session, in session 6, she was a little bit late. Okay. And she came in and she said, oh my God, I was late, on and on and on about being late. And I said, well, she said, I couldn't help it. There was she actually didn't say I couldn't help it. She said there was construction on the road. And I said to her, you expect yourself to know where all the construction will be. And she said, I should have read the paper. I should leave extra time just in case she was rolling. Okay. And so I ended up just kind of looking at her and saying to her, are you listening to yourself? Do you understand how cruel you are being to yourself? And she was expecting me to shame her. And she said to me, you're entitled. You're right. Your time is precious. And I said, who said that to you? Okay. So we were then, putting things together there, but you're absolutely right about the links together.
Chime in there, because when the therapist said, "Do you hear how cruel you're being to yourself?" That's making the unconscious conscious.
Question from Zoom.
Yeah, what's the question from Zoom?
Thank you. This is Mark Levy. I first of all wanted to thank Dr. Horowitz and Dr. DeWitt for a very, very interesting and valuable presentation and conference. So thank you both. Really appreciate it. Ed Weinschel, who was a good friend and colleague of Bob Wallerstein's and was the chief of training when I was a resident at Mount Zion during the golden years, used to say in a hopeless case conference, a brown bag lunch conference, that patients will always may not forgive mistakes of the head, but they will always forgive mistakes of the heart. And that really goes, I think, to the essence of what you, Dr. Witt, were describing in your clinical summary, and it goes to building a therapeutic rapport with the patient. And it's what Bob Wallerstein's 42 Lives, I think, really brought home, that it is the relationship between the patient and the clinician that makes for change, not necessarily any technique, be it orthodox or liberal. So my only point here was that I don't see, as I think Jonathan was being skeptical, I don't see how the various symptom-focused brief therapies, evidence-based for trauma, have so much evidence of their efficacy, because I don't see how you can treat the trauma in isolation outside of the context of easing the suffering of the person. And if there is good evidence that one of you could offer, I'd like to hear it. I don't see how 8 sessions or 12 sessions gets substantially rid of acute PTSD symptoms.
There is evidence, and I can speak to it. There's a big discrepancy between what we're told about evidence. You know, these are proven treatments. This is the gold standard treatment. This is evidence-based treatment. I mean, none of those words mean anything. These are not scientific words. Scientific words are, well, what if they're looking at the studies are looking at populations with a DSM diagnosis of PTSD, right? So a formal diagnosis. I mean, you know, scientific words is what percentage of the patients in the treatment group didn't have PTSD when they got done. You can't find that information in the article. They're not asking that question. What they're doing is they're taking the therapy, PTSD, you know, evidence-based treatment for PTSD. They're comparing it to a control group that either gets no treatment or sham treatment, and they say there's a difference between the group. Look, the difference between the group is significant. And then they take the victory lap. And nobody says, but wait a minute, what percentage of people actually got better? Now, actually, there are a number of papers that ask those questions, not by the original researchers. And you know, the finding actually across, there's a meta-analysis on this, across the so-called evidence-based therapies for PTSD, first of all, there's an enormously high dropout rate, around 40%, right? So 40% of the patients are voting with their feet right before they even get started. And typically the dropout happens after the first or the second session. Among those who do have the treatment, 2/3 of those patients still meet criteria for a PTSD diagnosis when they're done. So when I say there's a gap between the actual research findings and the rhetoric around the research findings, that's what I mean, right? So you could say these are evidence-based treatments, they're proven effective, but actually based on the success rates of the treatment, you could just as easily say they're proven ineffective. So,
Thank you.
I'm just going to say I have a habit of wanting to say too much. My context is that I've been studying intensive short-term dynamic psychotherapy, and I started with somatic therapy. I relate to the comments you made about wanting to have a therapy that relates traumatic symptomology, not just like regulation, but like integrating it back into the context and the feelings and the past, like all the links. And I thought that, what was I going to say here? That I really appreciated this aspect, but then I also had so many different things I want to say. So one is a question about, like, it was nice that you mentioned right at the end that she wanted to sue the janitor, or whatever it was. You said something about the bathroom not being clean, and she was engaging in a lawsuit. Did you say something like that?
No, it had to do with the fact that she fell in the airport because they hadn't emptied the refuse receptacles. So there was stuff all over the ground.
Oh, I see. That was going back to the original event. Got
it was the original fall. Okay. And so she fell because they hadn't spent enough time emptying the wastebasket.
Okay, so I'll skip that. That was a misunderstanding on my part. Yeah. So one thing is, I wondered if that anxiety or that fear could be seen as like the first thing that happened, but then it brought on all these these issues around embarrassment and exposure that didn't allow her to process the fear response. Because, in a lot of the somatic type of therapies, they would focus on processing the fear response, but I could think of it as like the character issues getting in the way. That was one like different way that I looked at it. The other random thoughts I had were, you talked about like, the over-contained or the under-contained interpreting versus like supporting. And it seemed like this was a mixture, right? And there were interpretive comments, but they were supportive. I'd be curious to hear which side you put her on. There wasn't, which is so primary in ISTDP, just inviting, like not having to interpret, just inviting feelings. So I'm curious about that, why that's, where that fits into the picture. And then my last comment is just a side comment that I think it's hard to talk about the culture wars in a very general way, but that maybe there's conflict, right? There's conflict between groups and conflict in experiences, and people are trying to deal with them psychologically. I think actually psychoanalytic or these types of ways of thinking are very useful in being more depthful in working with the issues at hand. All right, I'm done.
I'm trying to figure which one to to address. Okay, she did talk about fear. She certainly was afraid of humiliation. It was interesting in the paper at that time. There was a cartoon character that looked like a duck, and the cartoon character said that they were surprised to learn that you couldn't die of embarrassment. Okay, and I thought that it sort of hit into a very important psychological knowledge, which is that humiliation, embarrassment feels like the death of the soul to people. They can't stand that feeling of true embarrassment. It's different and unique, and it's more primary. Okay, it's getting caught with your pants down instead of feeling guilty, which is more developed. So it's an early one. It's age 2, et cetera, where kids are embarrassed. And so I think what I'm trying to say is, if you just behaviorally go to, you're really frightened, let's talk about what you're afraid of. you're not being sophisticated enough to relate to the person who is your patient in terms of who this is that the embarrassment is contained in. What's the language that you use to talk to them about? Do you not just do associations? Do you instead talk about the essence of who they are? Okay. And that's very important. And it's also very, very sophisticated. Not everybody, particularly when they're describing these manualized treatments, that level of sophistication is not there.
We should let other people. Yeah.
I was just differentiating between the physiological fear and the fear that needed the soothing relationally.
I'm going to take it slightly different from physiological, just saying surges of emotion and the ability to process complex ideas. Of course, it's based on the current physiological state of the brain circuitry, and it's really complex and messy. And so it's rare that you could make a decision as a therapist. But let's just take the example that you were talking about embarrassment. The patient in the example is in a relatively brief therapy. This is the 5th session we're talking about. The therapist is able to say something that I will abbreviate as, you are so vulnerable to feeling ashamed that you figured your fall was due entirely to your awkwardness and you don't want to remember it or do it. But it was due to a complex series of circumstances, and you didn't fall because you were 8 inches taller than your sister, or because you felt ashamed of yourself as a child. You fell because there was slippery stuff on the floor and they hadn't emptied the wastebaskets. And the patient, as a result of that, as in the follow-up to therapy, sued the airport for poor maintenance, meaning it's not entirely my fault for falling and having a bone injury. It's a complex situation. And so I'm going to go to improve the circumstances and get reparations.
Exactly. Instead of being a victim and blaming herself, okay, and she got mad. Okay. Now, I didn't go there with her in the therapy, and it was kind of interesting because both lawyers on both sides of the thing came to my house to take a deposition. This is not one of my favorite things. And so she had given permission for this. And what the airport lawyers were claiming was that she had concocted the depression and come into the treatment in order to be able to have evidence that she was injured so that she could then sue the airport, okay, which was just, and get her pension back, which was just, it's sort of like
the broken bones didn't count as evidence of injury.
I mean, you just sort of go, holy shit, okay. So what I had to do was go through my records of treatment and say to her, absolutely not. This is not, she didn't even have it in mind, the idea. She wasn't that aggressive. This came later when she was talking to other people afterwards, when she was settled down and could now cope. In other words, what we're talking about is very complex content and process. And now however, if I've got her in my office and she is really frightened in the moment, then I may not have been as talkative as I was with her, but she was very intellectual and intellectualizing. So the way to settle her down was to talk to her. Okay. With another patient who wasn't as intellectual or intellectualizing, I would have said, oh, that's really awful. That just sounds horrible to me. How are you doing? See, so you have to tailor it depending on the nature of the patient. If you have the idea that every time that somebody is frightened, you go into soothing, you're wrong. Because with some people, if I said that, I'd make it worse. She would have been more embarrassed if she said, I feel frightened, and I said, oh, that's a shame. See what I mean? She would have felt more ashamed. Okay. So it's a pretty sophisticated thing that we do when we try to individualize treatments.
And Kathy, can I just piggyback on that? And I think you're saying this, but I want to be sure that her gesture to sue the airport was actually evidence of psychological change that had occurred, where she wasn't exclusively self-blaming, and instead there was space for the situation to be more nuanced. We could imagine another patient where maybe characteristically they externalize all blame outward to the world, and then suing the airport wouldn't have necessarily been evidence of psychological change. Just So there we see tailoring the treatment to the patient, but also listening for the change, being very individualized about how we're identifying change, psychological change.
Right. I mean, I was floored when I got, I thought, holy shit, this woman is suing, because she just was so dignified, and so I didn't think she'd do something that aggressive. And it made sense. I mean, she lost her, the stuff was all over the floor. She fell, she lost her pension. So she was trying to recover that and pain and suffering. It made sense. But she would not have been the kind of person who would have made a fuss. See what I mean? Initially, she wouldn't have made a fuss. It would have been kind of crass.
Oh,
so it's not a fully formed thought, but I'm somebody who's worked in the field of early childhood trauma for the last 30 years. And so I have a lot of feelings about the characterization of the culture wars and a lot of feelings about the characterization of trauma-informed systems. But just thinking about how danger reminds the body of danger, and we work with children under age 6 who grow up to become many of your clients. And so I was very interested in thinking about she had rheumatic fever and what that would have been like to have your body out of control in that way. And then what it would have been like to have a child where you feared that they almost died. And then what it's like when we think about the concept of reminders to walk into a pediatric hospital. And then what it's like to have your body feel very much out of control as you age and you worry. And that this is the sequelae of what we see often, and that is one of the ways that I integrate a trauma-informed perspective in terms of thinking about Alicia, who is here, who is my mentor. Our visual is a triangle, but it's very different than the cognitive behavioral triangle, where if you look at how a person is showing up characterologically or otherwise on the right-hand side, behaviorally, characterologically, emotion-wise, you're really looking at the layers of experience on the left-hand side. And that just thinking about experiences of danger, and then thinking about experiences of danger that we might not think would have such a serious weight, but that because they remind the body of danger, they send the person reeling. And then to bring into the cultural context, the idea that, we don't know what the race or ethnicity or, of this client is, but for many of our clients, when they do go to their doctors, they are not treated well. They are not treated respectfully by the airport personnel because of the ways that we see them. And so that becomes another moral insult where you don't have safety in your body and you might not have safety in society. And that would be the way that we would want to be aware, because a big part of trauma-informed care is to acknowledge the past and to be able to deeply acknowledge when harm has been there, so that we partner in repairing with deep respect for the person that's there. So I just wanted to put this out there just because I've sort of been swirling and thinking about, the intersection, because I think with Alicia, we do very much also think about defenses. And I think, Dr. Horowitz, so much of what we do is built on what you did and what you created. We wouldn't have had PTSD, and just also, so just deep respect and thanks for you and your work. And also just thinking when you start with a very thorough assessment. And so that was something that Alicia told me and taught me, is to have how do we form that relationship where someone could tell us about possible experiences of having your body sexually used in ways that you did not want that might lead to those things. So I just wanted to put that out there.
Very good points, and I absolutely agree.
Thank think Dr. Jacobs was next up here in the front.
Yeah. I haven't spoken in public in so long, I'm not sure what's going to come out. Marty, thank you so much, and Kathy, great talk and great illustration. Jonathan, thank you for situating a discussion for us. And I just wanted to pick up on the case a little bit, because Marty, you made the point, and I've always been interested in how the new narrative is important in the recovery from a traumatic event or trauma, complex trauma. And we had an example of that in that session where she said, there may have been a good thing that came out of all this in terms of my being able to let my son help me and give him that experience, which I think is valuable. So that jumped out at me. And I also wondered if that got picked up more, which represented a different kind of pathogenic belief about dependency and control, differentiated from the humiliation and embarrassment. And maybe it's just a sign that there's a lot of places to go. But I was interested in that moment when she found something good, and that could lead to more good in terms of developing healthy dependency.
Yeah, the thing that was interesting for me about that is, basically it's a good example. The woman is unusual in terms of the fact that she went there on her own. Okay, so that is, she made the connection that went to the fact that I need to be in control at all times, the fact that I get embarrassed if I have a need, I get embarrassed if I'm out of control, also has an impact on my children and the way I relate to them. Eventually, she related it back to the fact that she, in the session, she says, I like to help my parents, but also she talked about the way in which they didn't like to be helped by anybody in the community. So she already was rolling on that theme. And so I just followed her on that one. And she made significant shifts in all her relationships about being able, the embarrassment was having to admit that she had a need. She's supposed to handle everything. She's supposed to be self-sufficient. She's supposed to be smoothly handled. And so that was, once again, it was humiliation. Okay. And so she got able to talk about it. Now, this, of course, is a central issue that underlies narcissistic character disorder, is humiliation, usually. And so people have become more aware of it. Recently, one of the lectures that I would do in the department has to do with NPD, collateral damage from it, blah, blah, blah. And sometimes it was kind of hard for the residents to totally grasp it. With Trump, okay, now everybody gets it. It's like you get the poster boy, and I can just really get them to understand that he is fighting humiliation by being grandiose. And so that dynamic was a little bit there for her, but in a very different style. Okay.
So we have about 10 minutes left. I'm happy to take more questions. I'm curious if there are any questions, any more questions from our virtual attendees.
Yeah, I did have one.
Yes, go ahead.
Okay, I'm Connie Milbrath, and I worked with two of the people on the stage, Dr. Horowitz and Kathy. So thank you so much for allowing us to participate via Zoom, because it's just wonderful to be able to be there from my Canadian perch up here and to listen to your wonderful presentations. I did want to ask Dr. Horowitz if there was any consideration when you're formulating the case is as to what kind of trauma has occurred. For example, specifically in loss, you have parental loss and spousal loss and child loss. And I know that those all have different ramifications or consequences for the person. So I just wondered if you had any thoughts on that.
Thank you. I have a thought, and it's a welcome opportunity to add it in, which is while it's complicated in terms of multiple topics, that the idea of losing a parent, child, a sibling, professional worker, whatever, there's all those ramifications. There's also the issue that you've lost your part of yourself, that is in relationship with that person as alive and reflecting on your existence, which is an important way of feeling stabilized. And some patients have the experience after the loss of a significant other, they expect to be pining and yearning for the person and for the opportunity to be with them and connect with them. But they're often surprised that they feel a destabilization, fuzziness, and cloudiness in their own sense of living life as a person with identity and some pleasure in living. And they feel very frightened of that because that's not what they expected. They expected grief and pining. And so it's an important issue as part of even the psychoeducational aspect of a good psychotherapy, to let people know that that's not an unusual experience, because loved ones who have been lost when they were alive were reflecting on the self. And so it's important not to forget about the deceased, but to remember the relationship, and that has an important presence in the life of the person. That's an overly brief attempt to make that point, but I'll leave it there.
Thank you.
You know, the other thing is that about that, Connie, was what I remember is we would look at death of a spouse, death of a parent, adulthood, death of a child. You would have a typical, you would know what the typical issues are in terms of who the loss is, what's going to how long it's going to take. Death of a child is, lifelong in many ways, because every episode, every time that there's a stage that they would have been that old at, they're not there. And, telling, what I found is that sometimes that's very useful in treatment, that to say to someone, death of a spouse this is going to take you 3 to 5 years. This is not going to be something you're going to get over this year. Okay. Then they don't feel weird. They kind of settle down and they can do the process of grieving. So being informed about those kinds of different characteristics is very useful and specific.
So everybody, we have 5 minutes. Other questions, other thoughts, anything bubbling up for you right now, Jonathan, or for people seated in the audience?
I was just thinking as I was listening to Kathy, that this is the most common response we see with trauma, that, something terrible happens to the person and they think that there's something horribly wrong with them because of their response to it. And that part of the work, first of all, psychoeducation about, actually, this isn't unusual. Right? That's the starting point. But when I say something like that, I'm not saying it just for the purpose of reassuring the person. I'm the authority, and I'm going to tell you that you're normal and it's really all right. What I'm actually trying to do is open space for them to have their own experience of it, for them to explore their own experience. So, if we can shift from, I'm having these responses to it and, look how bad I am, if we can shift from that to sort of curiosity about the range of experiences, and then we get into the areas that Marty was talking about it's not one experience. It's lots of different, often unintegrated fragments of experiences. And can we create a space where it becomes possible, right, to bring all of those things into the therapy relationship? And that's how I would call integration. You were calling restructuralization. But that's how it happens, right? We have these different fragments and compartmentalized pieces of experience, and we'd like to help the person bring them into relation to one another so that they can become more whole. So, to me, there's a kind of a sort of gray area between what's psychoeducation as in offering information and, how do we open space to allow more of the patient's experiences into the room and into their consciousness. Do you agree?
A question here in the front.
So I just want to thank Marty and Kathy for a wonderful presentation. I've had the pleasure of knowing Marty for, I can't believe this, 50 years. When I worked at Mount Zion while Marty was there as a lowly research assistant, but we happened to share space in the same building called the Dream House, which was a small Victorian building. So I got to know Marty pretty well at that time. And I was just impressed how in the presentation you gave today, it's a really a great summary of 50 years of your work summarized in a beautiful 1-hour presentation. So I thank you for that. And Kathy's a very gifted clinician, and I've also known Kathy for a long time. And the case is really fascinating. It opens up so many interesting. We could probably spend another hour or two on the case, but I just want to reiterate what the woman in the back said. I don't know her name, but the woman who worked with Alicia Lieberman, which is about contextualizing, that when we talk about personalizing and tailoring psychotherapy, what we're really talking about is contextualizing what we do to the specifics of the patient. And I think what the woman was commenting on was the embarrassment and the shame that this woman was dealing with didn't come de novo. We don't come into the world with those things. She had real experiences in childhood that predisposed her to that, and that trauma reactivated those things. And I think there's something incredibly useful about that contextualized approach to psychotherapy, which a lot of psychodynamic work does. So I thank you very much for that.
So everyone, it's 4:00. I don't know if any of our discussants or if our distinguished speaker have anything else to share. If you do, now's the time. And if not, I'm happy to close things out. Do you have any words, Marty?
Thank you, Kathy. Thank you, Jonathan. Thank you, Joseph. And thank you all the people from Canada to here in the auditorium. It's been very invigorating for me to be with you and hear these ideas.
Thank you. That's all. Just wanted to conclude by saying thanks to all of you who came in person. Thanks for everybody who attended virtually. And I realize we just clapped, but let's just show some appreciation for our two wonderful discussants and for our distinguished speaker, Dr. Marty Horowitz.